Hello, I'm Melissa Barnett, and I'm so happy that you're all here today in celebration of World Keratoconus Day. And I'm very pleased that we have an expert panel. So I have Dr. Barry Iden and Dr. Brandon Ayers with me. So I'm going to have both of you introduce yourselves, and we're going to get started on a good discussion about keratoconus.
My name is Brandon Ayers. I am in the Philadelphia area, and I am a referral surgeon for anterior segment disease, cornea, and cornea problems, which certainly includes keratoconus.
Excellent.
I'm Barry Iden, and an optometrist, and I practice in the Chicago area, also emphasizing specialty contact lenses and the management of keratoconus.
And I'm Melissa Barnett. I practice at UC Davis in Northern California, and very similar to Barry, do a lot of cornea, contact lens, and disease-based practice. So let's get started with this great conversation. So let's begin with the biggest challenges around keratoconus. And I'd like to start first with the prevalence. So how prevalent is keratoconus? Barry?
Thank you, Melissa. Happy to answer that. There are two different ways to look at it. There's the classic way that's been taught in various programs over the years, and the number that typically is stated is 1 in 2,000. We now know that that is based on a study that was done many, many years ago, and the diagnostic criterion was based upon distorted keratometry findings or abnormal retinoscopy findings. And we know that with newer technologies, much more sensitive technologies, that we're able to detect the disease much earlier. So now a variety of studies have come out to show prevalence at much higher levels, typically somewhere in the neighborhood of 1 in 300 to 1 in 500, depending upon the study and location of what is being presented. So.
Great point. And Brandon, what sort of diagnostic technology are you using in your practice to diagnose keratoconus?
Well, we're really spoiled because I live in a world of specialty anterior segments. We've got all kinds of ways of looking at the cornea. We'll use what are called placido disc-based topographers, which is basically it shines a concentric ring of circles on the cornea, and then it reads the reflection pattern and looks for distortion. We also use what's called a tomographer, which is a different way of looking at the cornea. But basically, what you're looking for, it doesn't have to be fancy. You're just looking for somebody in the right age range profile who has changes in their prescription kind of visit after visit. And that, I think, is really your first way of looking at and screening for keratoconus, even before you get to the fancy imaging systems that we have access to.
Great point. And Barry, what else are you looking for the diagnosis of keratoconus?
So surely in a primary eye care practice, as Brandon was referring to, you have to look for those red flags. Those red flags could be subjective symptoms, monocular double vision, halos or glariness at night, especially more in one eye than the other, and especially in a younger person. We also look at classic concerns and refractive changes. Asymmetry, I think, is one of the big keys. Increases in astigmatism that are asymmetric, maybe even increases in myopia that are asymmetric between the two eyes. That asymmetry, I think, is a big clue to be concerned.
Excellent. And Brandon, I think you're probably alluding to retinoscopy, that we can use retinoscopy, we can use autokeratometry or keratometry, but imaging of the posterior cornea is so helpful when we're diagnosing keratoconus. So I think we have a few cases that we're going to share, and let's get those slides going. So here we go. Okay.
So this is a patient of mine, and it brings back a lot of the things that we were just talking about. So again, when I saw this patient, it was the pictures we're going to look at are the first time that I saw him, but this was actually picked up by his primary eye care provider because he's a young patient, 15 years old. And on the past 2 or 3 exams, he had noted increasing amounts of astigmatism and asymmetry, just like Barry and you had mentioned. and was concerned that the patient may have keratoconus. So now the little picture on the left is just an example picture. That's not my patient. It's the pictures over on the right where we have what's called a pentacam, which is a Scheimpflug photographer, one of the fancier ways of imaging the cornea. And Dr. Barnett, it does image also, of course, the posterior cornea to maybe give us a little bit of an earlier clue that a patient may have keratoconus. But what this is showing me is a fairly high level of regular, what right now looks like regular astigmatism. But to give you guys a little idea, he's a little bit of a myope, a little bit nearsighted, but he now has 3 diopters of astigmatism in the right eye and about 5 diopters in the left, which is certainly becoming off the bell curve of what you would usually see in a 15-year-old boy. Now, to make things more interesting, his dad has documented keratoconus. So we have a family history. We have increasing amounts of astigmatism on multiple exams, and we have a topography that to me is worrisome, but not necessarily diagnostic of keratoconus. And this is the right eye. I believe we probably have a picture of the left eye as well. So this is the Placido disc-based topography, not the Scheimpflug topographer, but another version. Again, it shows the same thing, but the nice thing here is it shows this the images of both the right and left eye together. And you know, Barry and Melissa, if you had a patient 15 years old with a dad who had keratoconus, and this is what you're looking at in front of you, you know, what are you thinking about this kind of a topography?
Well, from my perspective, I think you're right on to be suspicious of keratoconus due to that magnitude of astigmatism and the asymmetry. In fact, one of our technicians at our practice, whose husband has keratoconus, has a 2-year-old child that we've already examined has high astigmatism. So she's just assuming that her son's going to develop keratoconus, and we're about to do some genetic testing on this young man. But you can see from the Placido analysis, and I believe this also has aberrometry associated with it, that at this point, even the posterior cornea does look pretty normal as well as the anterior. But it's the magnitude and the asymmetry that would make me suspicious to go on to the next level of testing.
Right.
In addition, I'd want to find out more about this patient. Do they have allergies or asthma or atopy? Is there a history of eye rubbing? Are there other associated systemic conditions like Marfan's or Downs? But agree with all the comments previously noted about the asymmetry and the magnitude. That's pretty concerning.
So my concern with these patients is that, at some point somebody goes from a normal exam to an abnormal exam. Right. Most people aren't born with keratoconus. They start with some refractive error that looks non-threatening, and then eventually it turns into this pathologic sort of pattern. And now that we have some treatments that can stop the progression, I feel like it's my job to take these patients who are suspicious and try and find them as soon as we can, so we can stop the progression and keep them from going on to more difficult shapes of the cornea or more progressive keratoconus, which can be much more challenging to treat. So I am worried about this, and I'm a little bit worried that this may turn into what's called a truncated bow tie, which is a somewhat normal looking pattern on topography, but you have the thinning in the posterior cornea. And it can trick you. You can look at the pictures and think it looks normal, but really it's keratoconus underneath. High levels of astigmatism. It's a little bit at a skewed axis, but it shows about 5 diopters. And to me, that's somebody who is concerning. And I'd like to get a little bit more information on that patient so I know how often to screen them, because there really isn't a lot of guidance, at least not that I know of, as to exactly how often I should see this patient. How worried do I need to be about this patient? And what else can we do? So I want more guidance myself as to when do I bring this patient back? Well, one, do I give him a diagnosis of keratoconus today? If I don't give it today, when do I bring him back again to screen again to see if we're seeing progression? Because in my book, if we see 2 exams that look different, one's progressing from the other, that's probably keratoconus.
So did you do any additional testing for this patient?
So I did, even though I knew that there was a suspicion, family history, I wanted to get genetic testing, because for me, that's going to be a real important part of my gestalt for this patient. How worried am I, and when am I going to bring him back? So I believe that we have we did the Avellino genetic test, very simple in-office test. It's just a cheek swab. within a week or two, we'll get basically a genetic risk score. Now, let's see if that is, if we have that slide coming up. We should have his genetic screening in here. Now, what's interesting about genetics and keratoconus, it's very confusing. It's not a one gene kind of a disease where there's a yes or no. There's over 70 genes. We keep adding more and more to it. And so you end up getting just basically a risk score, which only comments on their genetic risk. We think that keratoconus is probably a combination of environment and genetics, like you had mentioned. But I can ask him about, do you rub your eyes? Do you have asthma? Do you have sleep apnea? Do you have floppy eyelids? Things of that nature. We can ascertain some of the environmental factors, but there's no way I can look at a patient and know what his genetic risk is.
So in the father who has keratoconus, we saw the imaging, and it looks like the case has a 76 or high risk for keratoconus on that polygenic risk score.
His risk score came back high risk at 76. So that scale goes from green, which is don't worry too much, to red, which is worry quite a bit, and he was in the red zone.
So what were your next steps for this patient?
Well, I was going to ask you guys, but my next steps, I didn't think that with what I had right there that I could label this keratoconus. It was still regular astigmatism, but he's got high levels. He's got asymmetry. He didn't have any risk factors like asthma, atopy, any of those, but he does have a dad, and he's got a high genetic risk score. So for me, at 15, 16 years old, that means in about 3 or 4 months, he's going to come back, and I'm going to scan him again. And I'm going to look and see if there's any changes, because I want to catch this as early as possible. So I think if that risk score had come back low, I would still be worried about him. I wouldn't say, don't worry about it, we're not going to be concerned about you. But maybe I would have done a 6-month or 9-month exam. But he's coming back every 3 to 4 months until I don't know when, but I'm going to keep a real close eye on him.
Yeah, I would actually do the same thing. I was going to say 3 months because he's 15, and I imagine the 15-year-old is growing and changing as well. So he might be growing, his eyes growing, and it's a prime time to look for progression. I'd also counsel on, even though he didn't have any allergies or any symptoms there, but counsel to avoid eye rubbing. And if there were signs of any allergies, to actually treat that as well.
Yeah, I'd agree with everything that you guys are saying. And of course, coming up with that appropriate interval of follow-up is, at this point, sort of guesswork for us, right? We're kind of trying to figure this all out ourselves. In this particular case, we wouldn't label the patient as keratoconic, but surely high risk to develop keratoconus.
Right.
We also have to consider what are the treatment options that we have for patients. And here in the US, as we know, FDA-approved method is an epi-off cross-linking method, slightly or somewhat invasive. So maybe we'd be a little bit more conservative in terms of, instituting that sort of treatment until we were definitively sure about the situation. Maybe in the future, as newer technologies are developed, even less invasive, minimal side effects, maybe we'd be more aggressive at prophylactic treatment, perhaps.
Well, Barry, I'll tell you, my son, a couple years ago, he was about 16, 17, and he had never worn glasses. And suddenly he came in saying, Dad, I can't see the screen or the board at school. And I was positive he had keratoconus. As a specialist, you're like, he's got to have keratoconus. So I brought him into the office and, did topography, and he's a minus 0.5, a teeny little bit of myopia. He's got no problems at all. But I was ready to cross-link him right there if I thought he had keratoconus. Right. I'm very aggressive with cross-linking. Yeah. And luckily, we've been a part of a couple of FDA trials looking at epithelium on cross-linking, and we're really keeping our fingers crossed that we get the okay from the FDA for epi on. Because if we get that and we decrease the recovery time, and we would probably also decrease some of the risk, especially with infectious keratitis, making the epithelial defect, I tell you, I'd have a very low threshold to cross-link even suspicious patients.
I agree with you 100% on that as well.
And that's why it's so important to diagnose early, so we can cross-link early, so we can stabilize that cornea and prevent any progression and maintain vision and prevent vision loss.
That's our mantra, isn't it?
Yeah.
Absolutely.
So I think we have another slide here, and Barry, it's your case now.
Well, I think this is a real interesting one. And I kind of want to set the stage for this a little bit before I go into the profile of the patient, which I outlined here. Um, the the interest in managing progressive myopia is increasing worldwide in all of the eye care professions. It's a hot topic. It's something that everybody is kind of really starting to consider adding to their practices. So that's why we wanted to use this particular case example. And this is actually a patient of one of my wonderful associates, Dr. Tran, who just 2 weeks ago, when I was out of town at a conference in Italy with Melissa, she saw this particular patient who was referred to our practice for myopia management. And it's a 10-year-old Caucasian young lady who had progressive myopia over the past couple of years and a family history of myopia. She wears glasses full time, but the parents, as well as the patient, were really interested in considering orthokeratology or corneal reshaping with the hope of reducing dependence on the glasses and, more importantly, slowing down potentially the progression of myopia. Now, when my associate performed refraction, it was a spherical refraction, unlike the other case that Brandon was talking about, which would surely make one very, very suspicious. So here you just had a kid who's 10 years old, became a bit more nearsighted, now at minus 175 in the right eye, minus 1.25 in the left eye. Why would you be suspicious? Typically, in the average practice, you wouldn't be suspicious. However, at our practice, performing corneal topography and, in fact, corneal tomography, we also have all of the toys like Brandon has. We're very, very fortunate. It's part of a pediatric workup that we do routinely because we're so sensitive to the presence of keratoconus in the pediatric population at a much higher prevalence rate. Take a look at the central corneal thickness. They're thick. 604 microns in the right eye, 596 microns in the left eye. No significant history in terms of any allergies. She was asked about, or the parents also were asked if they observed any vigorous eye rubbing. All was negative in that particular area. But we ran tomography anyway. So let's go to the next slide and take a look. This is the right eye. And just for the audience that may not be familiar with Pentacam tomography, if we look at this classic, what we call the 4-map refractive display, in the upper left corner is classic axial curvature map. Upper right corner is elevation of the cornea on the front of the cornea. Lower right is elevation maps of the back of the cornea that Melissa was referring to. And then the lower left is global pachymetry, or thickness throughout the cornea. Now, if you take a look at just at the colors a little bit, the anterior cornea looks absolutely pristine, and it's no surprise to us. No abnormalities in curvature, no abnormalities in elevation. If you look at the global thickness, as we said, the cornea is thick and it's thick throughout. But if you take a look here in the right eye, there's this little hot spot on the back of the cornea. Not really abnormal, kind of borderline if you look at it. So we applied a software that is used in the Pentacam called the Bell and Ambrosio ectasia analysis. It looks for corneal ectasia in non-surgical eyes. These are kind of virgin eyes. And if you take a look, you'll see abnormalities, or at least borderline findings, on the back surface of the cornea. So all in all, this was analyzed at not being ectatic, but there is a little bit of a red flag on the back of the right cornea. But let's go to the left eye. It's a little bit more interesting. Here, things are a little bit different. It's a little bit more pronounced, especially on the back surface of the cornea. We can see a little bit of a borderline anomaly in the ectasia analysis on the front elevation, but we see a definitive abnormality on the back of the cornea. That being said, the global thickness and what we call the thickness distribution, or the change in thickness from center to periphery, was normal in both eyes. The overall analysis in this left eye was considered borderline. And in the right eye, overall was considered normal. But surely this was enough to spark our interest and to allow us to consider and offer to the parents, before we would do any myopia management treatment, to consider doing a genetic test. Parents, no family history of keratoconus. Keep this in mind. So we ran an Avogen genetic test to screen for keratoconus risk. And guess what? We just got the results today. I think I thank my friends over at Avellino for kind of moving things along so we could present them to you. But the risk was moderate. It was 39 out of 100. So what does that mean? Well, how did that influence our management? Well, I can tell you, just like you mentioned with the other case, Brandon, we're going to watch this individual much more carefully over time. We suggested, based on these appearances, to look at 6-month intervals. But could I justify 3 months? Absolutely could justify that. But the key thing, what we're not going to do is orthokeratology, even though they wanted it. Because in myopia management, if you apply orthokeratology, it can sort of often mask what's going on with any kind of progression of keratoconus, unless you're looking at the back of the cornea. We're fortunate enough to be able to look at the back of the cornea. So we'll consider some other options for myopia management, whether that might be daytime wear, soft lens in a multifocal format, or even atropine, low concentration atropine. So again, I think this is a really interesting case, number one, but number two, it's really important in consideration of what's going on in the eye care world, in consideration of myopia management.
So those are just excellent cases from both of you. Thank you so much. And when you did the genetic test, how did that play a role in your treatment decisions versus if you didn't have the genetic test for each of you? So, Brandon, what about in your case?
Well, I think with my case, I would have been left hanging and not really known what to do because I didn't have much of a guidance. And so, knowing in this case, knowing that he's at high risk for keratoconus on the genetic side, I am really going to watch him more often. I probably would have brought this patient back in 6 months or so to recheck him, but having that genetic data with me, I'm going to back that down to 3 or 4 months, maybe 3 months, based on your guys' input.
Let's do 3 months. You have to report back in 3
Okay,
months.
we'll do 3.
Okay. And Barry, what about you?
Well,
Same?
I think it's really perplexing if you think about that case. Imagine that we didn't have tomography. If we did topography, placido topography of the patient would have been perfectly normal on both of the eyes. We have a spherical refractive error in both eyes. What even makes you think about keratoconus? So this is really interesting, which brings out the point that I've talked about many, many times before in other meetings and lectures and presentations, and that is, man, we have got to move forward in getting advanced technology, the ability to measure the back of the cornea in some way, in an affordable way, and to make it accessible to the average eye care practitioner. Why? Because we know that keratoconus is far more prevalent than we ever thought before. We have ways to stop its progression. As you said, Melissa, we can preserve vision. We can save people's vision. But right now, it's only lucky folks like the three of us who have access to some of these really fancy dancy toys that can measure the things we need to. And it really made all the difference in this case. So we have work to do.
And I put it in a plug there for globally as well. So not just in this country, but globally.
Yeah, it's a worldwide problem.
Yes.
And curious for both of your cases, were there any siblings or other family members or cousins? How do you talk to your patients about having their families checked also for keratoconus?
Well, I can respond initially to this. So let's say we have a definitive keratoconic patient. Depending upon their age, of course, we always ask them, do you know of any family history of this disease? And invariably they say no, the vast majority. Some do actually know some that have it. But most of them, I'll then just ask, if they're an adult, do you have children? And how old are they? If they're younger, or even if they're a young adult, we'll ask, do you have siblings? And how old are they? And then they'll always say, well, I have a brother and he has perfect 20/20 vision. Now, that obviously to me doesn't mean that much. They said they just got their eyes examined. Well, we know that it depends on how you're being examined. What is the technology, or even what is the approach in terms of history of the things that you mentioned, Melissa? Now, with the advent of this kind of genetic testing, very simple, any practice can incorporate that. You don't have to have the fancy instruments to incorporate this type of testing in your practice.
Great point. And just a follow-up question for you, Brandon. So, when you get the test back, do you use the genetic counseling with your patients, or how do you actually review the results of the Avegen test?
So what I like about the Avegen test is, and I think it's the responsibility of the company to offer genetic testing anytime you're doing a genetic test. But with keratoconus, I turn into the genetic counselor. This test really looks only for corneal dystrophies, primarily keratoconus. We're not screening for all these, different problems. So we're gonna. This is a focused problem. We're looking for keratoconus in the risk, and so I get the test. We get the result back either on a follow-up exam or on a phone call. I review the data with either the patient or the family themselves, and I kind of answer those questions for them, because it's always going to be, what does this mean, in real terms? How often should I be seen, or how often should I have my kids seen, and what are we going to do? And so I review all of that with them. But it is really nice that Avellino does offer genetic counseling, both for the patient, and they can even help counsel the practitioner if they need some more information on it. So it's a really valuable resource that either the practitioner or the patient can make use of.
Yeah, I agree with Brandon 100%. And keep in mind that, similar to the three of us, we're really comfortable with understanding this disease, its implications, its management. So I function the same way as Brandon does. So we haven't had to utilize that particular service. However, there may be many practitioners out there that aren't as comfortable in managing these kinds of patients based on genetic data, and that type of service I feel can be very useful for those individuals.
Absolutely, Barry.
Well, excellent. Well, I really want to thank both of you for joining me today. I want to wish everyone a very happy World Keratoconus Day. I know we've been celebrating it for a month already in our practice, because why not? And thank you all for attending. Thank you for your time and attention.
Thank you.